Okay. Welcome, everyone. Good morning, mid-morning for you. I'm glad you're here today to be with us for some training about HIV prevention for medical practitioners. I'm Linda Riddle. I apologize that my camera is not cooperating today, but I work with the HIV program team at the Office of Main Care Services. Our speaker today is Dr. Stephen Rawlings. He's a board-certified in infectious diseases and internal medicine. He practices at Maine Health. He joins us today courtesy of funding from the New England AIDS Education and Training Program. And I'm really happy to have him with us today. He's enthusiastic and enjoys sharing this kind of information with practitioners. So I'll hand it over to you. Thank you.
Thanks so much, Linda. Thanks everyone for attending and all of those also hopefully watching this even offline afterwards. So I'm going to be talking about PrEP, and I'll kind of get right into it. The first thing I like to do when I talk about any of these topics is point out that just in 30 minutes, I might not be able to cover everything, or people sort of get a tease but want to go look for more. And I want to share a couple of resources that I find really helpful. So Linda mentioned I'm funded through the New England AIDS Education Training Center. They have a national body as well, and that national body funds two really great online curricula, the National HIV Curriculum and the HIV PrEP Curriculum. So those websites are here. And then we at the Gilman Clinic, or more formally known as, after a rebrand, we're the Adult Specialty Care Gilman Street Clinic. We're always happy to take questions, field questions, and help. Disclosure-wise, I receive no financial support other than from the NEATC and Maine Health. I've sourced the predominant, the data or information for these slides actually from the National HIV PrEP Curriculum. I don't feel like it's a copyright infringement because I'm teaching from them, but this is a national program funded by the CDC and HR and HRSA and hosted by the University of Washington. Well vetted, well regarded. And then the extra information at the end on lenacapavir I've sourced from a couple different places, including like the FDA insert. So just to kick it off, talking about how much we need HIV PrEP. So in the United States, there's an immediate need to increase the availability, implementation, and use of HIV PrEP. The data for this really comes from the observation that new infections of HIV have not significantly decreased. We still see on the order of 30 to 40,000 new HIV infections per year nationwide. The evidence has just accumulated that HIV PrEP is effective. It's on the order of 90% effective for preventing sexual acquisition of HIV and 70% effective at preventing HIV acquisition among people who inject drugs. But some of these numbers can even go higher when we look at injectable medicines like lenacapavir, which I'll talk about at the end. So it really can make a huge difference in an individual risk and as well on a epidemiologic scale, community-wide scale. It's also underutilized. We see no more than maybe 1 in 3 people who could benefit from PrEP actually receiving PrEP. And the landscape for coverage has really changed. It's much easier to get PrEP covered by insurance, even including things like laboratory medication costs. And so we really want to be trying to get more people on PrEP because it should be easier. There's always some implementation difficulty, but I'm trying to smooth that out and get people more aware so that they can deploy PrEP helpfully. Okay, so just to quickly cover the science of PrEP, numerous scientific studies have been done and published. Over 25,000 people have agreed to participate in this science, which is so important and helpful. And all of these studies resoundingly show HIV PrEP as safe and effective. I mentioned the 90% for sexual transmission, and it's around 70% in people whose transmission risk is thought to be injection drug use. But it could be even higher, and especially with really good adherence, and we just see such great protection that it's worth using. And so basically, I used to start these talks off with a bunch of delving into the science or different studies and what they found with this nuance and that nuance. But I think it's worth recognizing that the science is largely settled. What we really need now is more access, more infrastructure, and anything we can do to tweak or improve patients' adherence. So what are the hurdles and burdens? There's still a lot of stigma and there's still a lot of access issues to getting HIV PrEP. Um, we know it's efficacious, but it's underutilized and underprescribed. It's probably due to complex social determinants of health and how they play on each other. As an example of this, in recent years, Black Americans represented about 40% of new HIV infections, but account for only about 14% of people taking HIV PrEP. Other groups, such as people experiencing homelessness or people who inject drugs, can be very much at risk depending on other risk factors they might also have, and because of difficulties in accessing medical care for them, we see also decreased rates of PrEP offered despite their risk, sort of disproportionate to their risk. And also clinics. We need more clinics. We need more places that are providing PrEP, particularly in rural communities like Maine. And one reason to do webinars like this is to try to get a little bit more access outside of some of our urban centers so that everybody who could benefit from PrEP can get PrEP. We talk about PrEP also as sort of a care continuum, and I'll show you even just where that comes from in HIV care. But the obstacles are all along that continuum. So people may not perceive that their HIV risk is actually what it is. They may not have awareness of HIV PrEP. So even just those initial steps to making somebody aware of PrEP and their need for it is a problem. Once they know that they have it, it may be difficult. Once they know they have risk, it may be difficult to find a provider knowledgeable about PrEP, or that provider may have discomfort discussing PrEP. I'm hoping to break some of that down here today. And then patients may have low willingness to take PrEP, or there's concerns about side effects and costs. And so, even if we've gotten to the point of prescribing it, adherence may drop off if there are unexpected side effects and costs. And so, those are places where we can do work to improve. Um, and I mentioned costs, specifically things like the medicines or getting copays covered, clinic visits, and laboratory monitoring. It's unfortunately still not completely seamless, but with experience and with a little bit of foresight, a lot of these can be overcome, and patients can be on a very successful PrEP regimen. And then for some of our most impacted communities, there's still the potential for mistrust of the healthcare system, often or possibly related to past traumatic experiences with healthcare, and that can contribute to lack of HIV PrEP care, connection, and falling off that care continuum. And we'd like to just try to address that by increasing awareness and then some steps to overcome that stigma. I mentioned the HIV care continuum, and this is not totally the purpose of this talk, but it's just important. This is the origination of sort of that care continuum. We need to diagnose everybody who has HIV. We actually don't do that currently in the United States. So only about 87% of people who have HIV know of their diagnosis. We then need to link them to care, get them receiving their medical care and stay in care, and actually then we can achieve viral suppression. So that's the HIV care continuum, and a very similar one can exist as well for PrEP. We need to identify people who are at risk and make sure that they know that they're at risk and that they're a PrEP candidate. We need to gauge their interest and hopefully move it towards, pre-contemplative to willing to be on PrEP, get them in a program, get them on PrEP, keep them on PrEP, and get that adherence and persistence, particularly while their risk exists, so that they can continue to benefit from PrEP. And so, how can we overcome PrEP stigma? I think it's important to look at using stigma-informed and trauma-informed approaches to inform HIV preventative care. All healthcare professionals, when discussing PrEP, it's helpful to use inclusive, non-stigmatizing messaging. I like to, and the National CDC guidelines recommend normalizing HIV screening and conversations around HIV PrEP. So it's simple things like saying, instead of, I think you're at risk for HIV, maybe I like to screen all of my patients for HIV, and I want to make sure all of my patients who are sexually active know about HIV PrEP. Is that something you'd like to hear more about? And so that decreases any immediate stigma somebody might feel and sets it more in the background of a service that's being offered to everybody as part of their normal routine health care to keep them healthy. All of that should be integrated ideally into routine primary care services. And when necessary or applicable. For instance, we have a bit of an outbreak of HIV in the Bangor area amongst a specific community, people who've experienced homelessness and are injecting drugs. uh, Liaising with community members, using the language that the community wants, can really help. And we've seen that efforts like that are really helping us offer and get more PrEP out into the community in Penobscot County, where that cluster that I just mentioned is um, currently, we're having a response to. So if you're specifically wondering who should be offered PrEP, after the conversation around I offer it to all of my patients, the CDC, National CDC, put out this information in 2021. And I'm actually going to start at the very bottom, which is just anybody asking for PrEP should be offered it. And we may not need to know why they want it or what their specific risk is. If somebody comes in asking for it, you're actually like halfway down that PrEP continuum already. Let's just get on to a medicine, discuss what options there are, and then keep it going. But specifically, the National CDC calls out as particularly high risk anybody who's recently had an STI, so like a bacterial sexually transmitted infection, gonorrhea, chlamydia, syphilis, anybody with a history of multiple sex partners, inconsistent or not using condoms, they're in a relationship with somebody receiving somebody who lives with HIV, they're part of a network that has high HIV prevalence. So particularly like that community I mentioned in Penobscot County, experiencing a increase in HIV rates. That's somebody who should be targeted for PrEP. Anybody who is a transactional or survival sex worker, they are sharing needles or injection equipment with somebody, with anybody, or specifically if they have an injecting partner who's HIV positive. These are obviously individuals to be targeted for extra HIV PrEP information as well. I also, as part of that sort of stigma informed care, like to just briefly segue away from protection and encourage people to not be afraid to say the word condoms. So sometimes we talk about unprotected sex, but what we really are trying to say is condomless sex. And I think it's important, and this is actually derived from community members who've brought up this sort of language and messaging to clinicians like myself. So if you're trying to protect against something specific like pregnancy, condoms can do it, but also birth control or a vasectomy. And so you're asking somebody, are you using protection? And all they're worried about is getting pregnant. They may say yes when they're on birth control, but they're actually missing other protection, right? And so similarly, gonorrhea, chlamydia, yes, condoms can work. Maybe if somebody's concerned about that, condoms can help decrease their risk of bacterial STI. So can doxycycline post-exposure prophylaxis or testing and treating. So these are other mechanisms. Same with like HIV. While condoms are imperfect, it's often quoted around 80-90% protection from HIV acquisition. Some patients could choose instead to use PrEP, or they're having sex with somebody who has HIV, but they are undetectable, and that means they're untransmittable. I also like to point out, by the way, HPV often can be transmitted around a condom. So really, if you're trying to protect against HPV, we need vaccination. Okay. So this is a lot on the screen. I'm not trying to, I'll go through different parts of this, but this is a PrEP clinical starter guide that I and a fantastic preventive medicine fellow, Toby Nicholson, and Patrick Tolosky have worked on. Um, Main Care has this available. I think Linda's going to even drop it into the chat. Feel free to reach out to me and we'll keep this updated at Gilman Clinic. But the goal was to create like a single piece of paper that you could even print off. And there is a third page to this as well with just some extra details, information, footnotes. But this single piece of paper, double-sided, you could use with you whenever you're thinking about prescribing PrEP. And so I'm going to dig into it kind of specifically and go through the different rows. And the columns are 4 different options that we have medications for PrEP. So let's talk about those 4 medicines. There are 2 oral options, and as of June of this year, we have 2 injectable options. So lenacapavir being the most recently approved, as I mentioned, June 2025, got FDA approval. So the oral options are this long word, tenofovir disoproxil, fumarate, and emtricitabine, 2 medicines combined into one, more commonly known by its brand name Truvada. And then another oral option, tenofovir alafenamide, is similar but different, and that's Descovy brand name. And then the injectable medicines are cabotegravir and lenacapavir. And so in these columns, the official FDA approved indications for these medicines do have slight variations. So Truvada, Cab, and Len are all approved for all patients with a caveat that there's limited data in pregnancy for Apretude and Yeztugo, Len and cabotegravir. Sorry, I'll switch back and forth sometimes. I'll try to use the generic. Um, but for instance, Len recently was just studied in thousands of women who had just had pregnancies, and some of them did become pregnant on the medicine. So we're going to probably have data very soon on its safety in pregnancy. Descovy is the only medicine that the FDA approved indication specifically calls out a sex. Specifically, it's only approved for male sex assigned at birth. However, I'll show you in the next slide, there may be reason to use that in female sex assigned at birth as well. But so all of these can be used. They all have FDA indications for sexual exposure and essentially all patients. When we wrote this guide, we also included an entire column or row on harm reduction considerations, particularly thinking about the cluster in Penobscot County. But I think it's worth recognizing just as a practitioner how I would potentially kind of veer slightly from the specific FDA indications and help patients meet them where they are. So, for instance, for all of these, we do call out, for instance, like a point of care HIV test may be appropriate if you can't get phlebotomy. If somebody really just doesn't want to get to a lab for their first dose, it's probably more important that we get them on medicine and engage them in care than it is to get a specific type of test. I'll talk a little bit more about testing also later, but a point of care test likely is sufficient. Uh, Truvada is also available as generic, so that's listed here. All the other medicines are still brand name. People who are on gender affirming hormones do not need to worry about any of these medicines impacting their gender affirming hormones. There are some things about like a gluteal filler for cabotegravir is thought to be a contraindication. So if somebody has gluteal fillers, and then we'll talk a little bit about dosing and things like that in here. But even though they're not FDA approved for people injecting drugs, there's likely a lot of benefit, and small studies have shown that as well. So we wrote in here as well, consider for all populations. A comment just on the injectables and sort of to say the maybe scary thing out loud first. So there is this consideration when people stop the medicine of what to do. And so briefly for the oral medicines, for anybody stopping, if they have known hepatitis B, you do need to monitor for rebound of hepatitis B. And so that's just done with serial LFTs, usually monthly or every 2 months for 3 to 6 months. Cab and lenacapavir, unfortunately, do have a tail. And there's a hypothetical concern here, but also something that I think if you just explain to the patient and they are on board with it, you can then move on because it's still, again, so important to start. And so the thing to understand is that if somehow, and sort of this schematic shows like you have good dose or good level of the drug, good level of the drug, it's sort of above this protective line, but it drops off because you don't get further doses of it or you decide to stop, and somehow HIV is introduced at this point, there's a chance for resistance. And here's another schematic. This is actual data from cabotegravir and what happens when it's dosed or what the levels look like at the different dosing intervals. So it's normally dosed every 8 weeks. And you see here, most patients, participants in the study had concentrations well above the 4 times inhibitory concentration. So that's great. That's why it works every 2 months. If you then stop dosing it or don't get a repeat dose and you start looking out at 24 weeks, so half of a year, some people have dropped really quite low in their levels. And if you go even further to like a whole year, you're starting to have people who have detectable levels still, but it's really flirting with or well below now the protective level. The concern here is that if somebody got HIV at this point, that's kind of what this diagram also shows, that HIV could be exposed to a drug and learn how to resist the drug, anthropomorphically learn how to resist the drug. but uh, it's not therapeutic, and so you're going to lose a class of medicine. I'll explain in a final slide why I'm not worried about that. I think the conversation with patients is just that they need to keep getting their repeat doses, all their doses, if they want to continue the medicine, particularly if they think that they have ongoing risk of HIV. It's normal, completely normal, that people are going to decide, I'm in a monogamous relationship, I'm no longer on the dating scene, or I'm not injecting drugs anymore. I don't need repeat doses of this medicine. And that's where, we do comment here, you could consider offering them oral prep so that they have an option. Or I think it's reasonable to say that's fine. You believe your risk is now zero. We can let the medicine wash out of your system. If your risk ever changes, please come back. And then there's instructions on how to redo it based on the timing, but you'd essentially reload and get them back on protective concentrations of the medicine. So patients just need to understand that there's some small risk in when they're stopping if they're exposed to HIV again. But if they feel that their risk is zero, I think it's perfectly reasonable to let them stop the medicine. So how do you monitor and prescribe these medicines? Again, this is just straight out of the guide, so that's why it kind of looks like all these boxes. But for the oral medicines, we do recommend baseline checking. Of course, the HIV, I mentioned point of care testing or phlebotomy. If they're going for these other hepatitis labs, they'll get their phlebotomy that way. So this is needed or strongly recommended. Also, creatinine clearance, because there is some dosing adjustment or limits for these medicines at different cutoffs for renal function. And then consider, just as a baseline, either a viral load. It's worth getting triple site screening for the at-risk individual for gonorrhea, chlamydia, syphilis, Hep A, not because it's affected by these medicines, but just because it's potentially a sexually transmitted infection and they could get a vaccine for it. And then Hep C and also pregnancy. For monitoring for the orals, they get every 3-month HIV antibody antigen tests, and we try to do that around a week or so from the prescription. And the prescription is essentially take 1 pill daily. I'm not going to go into it here. There is something called on demand, particularly for Truvada, which is like 2 doses as soon as you know you're going to have sex, 1 dose 24 hours later, and a 4th dose 24 hours after that. But I'd rather talk with patients, particularly in ID, or explain to you my concerns and limitations. So I don't routinely offer this to patients. For the injectables, we're not worried about hepatitis B, and we're not worried about creatinine clearance. So baseline is just making sure that they don't currently have obvious HIV infection. And then we monitor that for cabotegravir. It's an every 2-month, essentially with their every 2-month dosing. And for lenacapavir, it can be every 3 months or every 6 months, again, with their dosing. There's then a recommendation to also just perform sort of routine STI for other STI screening, depending on risk. I mentioned it already, but so the cabotegravir is dosed every 2 months in intramuscular, usually in the gluteal region. There is a loading that is just 1 month apart, so they get 2 doses 1 month apart, and then they go to every 2 months. And now with lenacapavir available, that dosing is an oral loading dose at the start, and then 2 subcutaneous injections at the start, and then the subcutaneous is the only thing continued every 6 months. I'm going to kind of go through this quickly just so I can get to the yes to go slides, but there was a little bit, you may have seen previously, recommendation to get viral loads with every test, every antibody antigen test. And there was a great presentation from the WHO at CROI this past year, kind of refuting that. And sort of the backdrop to kind of go through this quickly is that we probably don't have anywhere near the amount of nucleic acid testing or PCRs that we really need. And it's actually probably not that important to do it, which I'll show you. And so the WHO is formally recommending not requiring NATs before starting PrEP. A lot of this is getting at a question about what would you do if somebody had recently acquired HIV, but they were negative on an antibody test, sort of like in this window here, and they got a dose of the medicine. And what the WHO did in sort of modeling studies is show that that's actually very low risk. And wouldn't increase really resistance. And you're not even going to really narrow this window period that much by checking HIV RNA. Instead, just do the monitoring labs with the every 3 or 6 month antibody testing, and that should be fine. And just to sort of bring that to a close, too, the International AIDS Society, which is different than the WHO, did in fact drop RNA testing from their recommendations back in December of 2024, even before Dr. Johnson's presentation. And so that's reflected in our guidelines as well. So in the last few minutes, I promised you some information about lenacapavir. We're really excited about this. This is received FDA approval in June. I think what's really exciting about it is just 6-month injection, 6-month doctor visits is potentially game changer for patients. A lot less frequent than the every 2-month injections. It's also kind of a cool drug. It's a completely novel mechanism of action. It works on what's called the viral capsid. Purpose 2, the trial that was largely used for approval, was actually ended early in spring of 2024 because of superiority. In that trial, they had 2,180 participants on lenacapavir and only 2 cases of HIV in that arm, which results as an incidence of 0.1 per 100 person years, compared to Truvada, kind of our old standby, that pill, actually had an incidence of 0.93 per 100 person years. So just a dramatic improvement when people are getting the injection. We're working on getting more Len in Maine. It's fully covered under Maine Care, by Maine Care under the medical benefit. There is this oral lead-in, I'll talk about it again, but it's 2 doses. So patients take 2 pills on day 1 and day 2, but that does have to come through a pharmacy benefit, and patients get it through the specialty pharmacy. Just this week, the J codes. I've learned way more about J codes in the past few months than I ever thought I would. But J codes went live in Maine Care just this week. Maine Health, and I've worked heavily on this, is going to be offering lenacapavir as PrEP at our ID South Portland location, the Gilman Clinic, the Penn Bay Infectious Disease Clinic, and Midcoast, which is in Brunswick, ID. And we would certainly look at offering it at more locations as needed. And the Gilman Clinic is happy to help at any point if you have a clinic that you'd like to get it started and you want any of our resources. So here's again the dosing. It's approved for adults weighing more than 35 kilos. They're going to get 927. It's just an odd number. Just sort of put this into your order system. It comes as a kit. They're going to get 927 milligrams by sub-Q injection. It's actually 2 1.5 milliliter injections. And at the very beginning for loading, they get 600 milligrams on day 1 and 600 milligrams on day 2. After that, it's every 6 months, just the injections, the 2 times 1.5 mLs. If anybody needs to stop or they're going to be really late in getting their repeat dosing, the same 300 milligram tablets can also be prescribed and taken once every 7 days. So it's convenient. This 4-pack of pills that's used at the start would also cover an entire month's worth of continuation if needed, if somebody was having trouble getting their shot. This is straight out of the package insert, how to give the shot. But just the points are they prefer the abdomen. The thigh can be used as an alternative if needed. You do want to kind of squeeze the skin, get in subcutaneously 90 to 45 degree angle, and you're creating a depot of the drug here. We've done it a couple of times at the Gilman Clinic. I have amazing nurses who'd be happy to talk to anybody, talk them through it. We also have a couple of tips and tricks for getting patients like some cold packs and if there's any pain. People do report some injection site pain. Often it resolves after 7 days. Last couple slides here, and I'm up against time, but I mentioned there is some concern about resistance and these injectables. And I just want to point out, I am not worried about this. I think it's more important to get people on PrEP, get PrEP that works for them. And the reason I'm not worried about it, by the way, is look at all the different drugs I have. If they do acquire HIV, I can still treat them. So it's more important to try to get them on something than to wait for the perfect opportunity or wait for them to think about like committing to all their follow-up doses. Somebody presenting for acute PrEP probably is at very high risk and should just get started on it. We'll figure out the future later. Here's some PrEP helplines if needed. I mentioned we created this guide both to kind of or to meet the middle in between sort of that thorough HIV PrEP curriculum and a brief handout guide from another group that I'll show as well. So feel free to reach out if you'd like it, or from Main Care. Just to be equal opportunity, there is also a one pager put out by my group, the AETC people. They have not updated it yet with Len, so that's another reason we made our guide. But this is a really nice one pager and has a lot of the same information. In fact, it was a resource for us when we made ours. And I don't know if I have time for questions, but I'm happy to take them by email or call the clinic if you ever need anything, and we'd be happy to help. I think I'll stop sharing.
Hey, thank you. I did have one question come in through the chat, but it's something that
Please.
relates to main care. Then I have to follow up on
Okay.
with the person. So, um, thank you so much for your time and attention today from everyone who's attending, and have a good day.
Thanks, everyone.